here it is. It's time to go inside EMS. I am your host, Chris Cebollero, and with me again is my good friend, Kelly Grayson. KG, welcome back to the show.
Good to be back, actually.
Yeah, man, we're going to talk about
10-year anniversary, man.
It is our 10
anniversary.
10 years tomorrow, actually. The 13th will be 10 years. We started this show. And, it's been a great ride. We've had over 600 episodes in 10 years. We get about 42,000 downloads a month. 81% of the people, of course, are listening to us in the United States, but we've got some countries that listen to us.
Awesome.
Folks in Jamaica, Saudi Arabia, Canada, Australia, Mexico, the UK, United Arab Emirates, and, it goes all the way down to the Philippines, South Africa. And we're certainly excited that people around the world that are tuning into Inside EMS, we're excited about that. And, 10 years, I didn't get you anything.
It's okay, man. It's just your presence is a gift enough.
Interesting.
When you quite sure how to feel about that. Pretty sad, actually. Nothing against you, but I'd hope for a long-lasting relationship with someone better looking, actually. So,
well, I mean, that's okay. I mean, I can't be the picture for everybody, but I'm glad that we still have a good relationship after 10 years. But one of the things that I want to share with the audience before we get going is, we've been recording now, and check us out on YouTube. EMS1 video on YouTube, where you can check out all the shows that we've done recently. And we're going to be building a big video catalog and some really great things to come on EMS1 video. So go ahead and check that stuff out. But, Kelly, one of the things that I think, we talk about is you're very, very busy in the EMS World Tour of training the next generation of EMS provider. And one of the things that I think is very, very admirable, and you do a lot of work, man, right? I mean, you travel around. We were just talking, you're going to be going to Connecticut again. You're going to be up in Alaska in November. And, so as you were MIA for the past couple of shows, we've talked about you being on the EMS World Tour. Of course, that necessarily wasn't the truth, but knowing what was going on and not wanting to tell your business to the listeners, we kind of kept up the EMS World Tour or being on special assignment. But you've been very, very vocal about what went on with you. Yeah. And I think that this is something that we want to be able to share, because I think from a standpoint of what was going on medically with you, as well as how to deal with those things as a paramedic, I think we're going to find. But you've written a couple articles on the fact. But, so recently you had a pretty serious medical scare. Maybe give the audience a little bit about what happened to you.
I had an episode on April the 14th at a literary writer's retreat in Wichita Falls, Texas, that turned out to be a massive pulmonary embolus. We had been socializing and eating and drinking a little bit, and the party was breaking up, and I went back to my cabin that I had rented. When I got to my truck, after walking just a very short distance, I was pretty short of breath, and I thought, "Ooh, I've got to get my fat butt into shape. This is not good. Look, a little drinking, a little good food does this to you." And by the time I drove over to my cabin, it was bad. And when I say bad, I mean like breathing 48 times a minute, hyperventilating bad. And I legit thought I was going to die. And on top of that, even though I legit thought I was going to die, I refused to call an ambulance. And, I can think of stupider decisions I've made in my life, but I can't really pinpoint one right off the top of my head. But the episode lasted, the acute phase of it lasted probably an hour. When I was breathing 48 times a minute, it was literally and desperate. And about 45 minutes into that, I thought to myself, I said, you're an idiot. Go inside the cabin, or people are going to find you dead in your truck in the morning. And when I went in the cabin, my roommate was in the bathroom at the time. When he came out of the bathroom, he just looked at me and stopped in mid-sentence, and I just pointed my finger at him very weakly and said, "Don't you dare call an ambulance for me." And collapsed on the bed. And he said, "Okay, you're the paramedic. I won't call the ambulance for you." He said, "But the moment you go unconscious, implied consent applies, and I'm going to do what I need to do." So came back. I cut my trip short by a day, and saw my personal physician Friday morning. And he ordered a battery of tests, and it turned out I had a DVT and a pretty severe pulmonary embolus. So lucky to be here. I'm lucky to be alive.
Well, I'm glad you're here. We wouldn't be able to celebrate 11 years. So, but Kelly, so I think there's a lot of things just to unpack here. I think one of the things that we don't do well enough, as paramedics, is take care of ourselves. And we try to, make excuses for the way that we feel. And we try to diagnose ourselves, right? And certainly before you knew that this was a pulmonary embolus and, DVT, what did you think was going on? I mean, did you really think that it was just an out of shape thing, maybe a little too much to drink? I mean, what was going through your mind? How'd you rationalize how you were feeling?
Well, I'm a paramedic. I'm capable of quite a bit of rationalization. It's odd. It's demonstrative of how stubborn paramedics can be, and how poor a patient that healthcare providers in general are. And it's also a pretty good peek into the mindset and our ability to compartmentalize and try to be rational and problem solve. So it's both a good view of the paramedic's mind, and a really great example of how stupid we can be. While this was going on, I'm trying to, 15 minutes in, I said, "This is not good. This is not just you being short of breath from exertion. It's not easing up." Chris, I literally felt like, you ever piss off your coach in high school football and he made you run wind sprints until you vomited or passed out? Okay, take that feeling and extend it for an hour. You don't get any better. You're just gasping. You cannot catch your breath. You're weak. And it does not ease up no matter how much you rest. So at the time, I'm thinking, okay, there's no chest pain. There's no nausea. There's no weakness. It could be an MI, but I don't think so. And my last lipid panel and so on and so forth, I don't really, other than obesity, don't really have any major risk factors for cardiac disease. And I tried to check my pulse. I thought this could be a tachyarrhythmia. I wasn't having palpitations, but I've dealt with plenty of people with tachyarrhythmias that only had severe dyspnea. And I tried to check my pulse, and my hands were shaking so bad that I couldn't check my own pulse. And I thought, okay, CHF. Well, I am in demographic now, but I don't have any problem with orthopnea. I have I don't have a problem lying back or lying down. It's probably not CHF. I said, I'm moving air. I'm not tight or constricted. It's not in type of bronchospasm. What the heck is going on? And after about 45 minutes of breathing like that and being unable to slow it down or get it under control, it occurred to me, God, you've been breathing 48 times a minute for close to an hour, and you're not having carpopedal spasms. And that's when it hit me. Oh my God, I'm having a pulmonary embolus. I can't breathe because I'm not uptaking any oxygen, and I'm not having carpopedal spasms because I'm not exhaling any CO2. Oh my God, I'm having a PE. So I said to myself, you need to get inside and where you can at least dial 911 if you can. and got inside the cabin, and I told you the rest of the story. I collapsed on the bed and told my after about an hour, and he came out of the bathroom. I was feeling marginally better, but still bad. And I told him to give it a few minutes. And after an hour and 15 minutes, I was okay. Not great. The rest of the night, if I got out of bed to use the bathroom, I could walk 20 feet and then have to sit on the side of the tub for 5 minutes to catch my breath. And that went on for close to 24 hours before it kind of evened out. But yeah, denial is more than just a river in Egypt. I had some pretty serious denial going on. And but the whole time I was telling myself, trying to fight back the panic and trying to tell myself, okay, figure it out, work the problem, try to diagnose and see what's going on here. And then I realized, why the hell are you doing this? You're just doing this so you can die knowing what killed you.
And right.
And that was
that's the question. Yeah, that's the question I want to get you to. I mean, as you were going through the differential diagnosis of figuring out, and one, it took you way too long to figure out what the heck was going on with you. 45 minutes to figure out that you were having a PE.
Well, you try to make your brain function when you're breathing 48 times a minute.
You may, I mean, I'm just saying, you may need some continuing education. But let's ask you this question though, Kelly. I mean, at one point, you finally got there and you said, oh my God, I'm having a PE based on everything that you were feeling. What the heck were you thinking that you didn't want to go to the hospital at that point in time when you finally got there to say,
I wasn't thinking,
you know what I mean?
I wasn't thinking. At the time I had I was in Wichita Falls, Texas, and I did not want to go to a foreign hospital. I didn't want to go to a local hospital. That particular hospital, I mean, it's a Wichita Falls, a fairly decent sized city. But I kept flashing back to a good friend of mine who had called me from that hospital and said, who was present at this event, said, "Hey man, they're about to send me to the cath lab for a global MI." And I said, "Okay, what's a global MI?" He said, "Well, the doctor said I'm having ST elevation in every single lead." And I was like, "Oh, dude, you wouldn't be talking to me if that were going on. Tell me what's going on with you." And he gave me the history, and I asked a few pointed history questions, and I said, "Dude, you're not having an MI, you're having pericarditis." And they were going to send him to the cath lab for ST elevation every lead, which is, as we know, is one of the cardinal signs of pericarditis. So I said, mention that before they take you in there. And he told the cardiologist, he said, "You don't think it could be pericarditis?" And he said they stopped moving his bed, and the cardiologist looked at him and said, "Hold on, sit up, lean forward." And Ian leaned forward a little bit and grimaced, and the doc just kind of rapped him on the chest with his knuckles. And he said, I levitated off the stretcher and yelled. He said, yeah, let's cancel the cath lab. I'm pretty sure you have pericarditis." So that was the hospital I would have been going to, and I was none too sanguine about that. And I really wanted to see my personal physician if I was going to go anywhere, and I wasn't going to go to an ER. I thought that the best person to decide what to do was my personal doctor, which was kind of stupid. So I really wasn't thinking. It was just purity. I'm a paramedic. Paramedics run the ambulance. They don't call the ambulance for themselves. And I was damned if I was going to call EMS in Wichita Falls, Texas, and have the paramedics get off the truck and go, "You look familiar. Do I know you from somewhere?" So
Yeah, but you were
I
only
wasn't going to have that happen.
1 hour away from Fort Worth too, as well. So you could have went to some really good hospitals, really good heart hospitals in Fort Worth. But
Yeah, I
yeah,
could have gone to any major world class
yeah.
hospitals in Dallas or Fort Worth, and I just didn't.
Yeah. So, but anyway, I mean, so it's interesting. So, I mean, let's switch gears a little bit, right? I mean, so we know what happened with you. Let's talk about, some of the things that happened clinically with you. And then I really want to kind of end with if we come across this in our day, how do we deal with a patient that's feeling what you felt? But first off, maybe take us through a little bit of the diagnostics procedures. I mean, what did they do to confirm it? What did they show? I mean, so what could someone expect, or as a paramedic now talks to a patient that may be having a pulmonary embolism, who's going through what you're going
Yeah.
through? What do we share with them of what to expect once we get them to a hospital? The real people that go to a hospital, not you. I mean,
real people to go to a hospital. Well, if you put a nasal capnograph line on someone who's having severe difficulty breathing, and there's no mechanical reason for it, they're moving air well, they're ventilating fine, yet the pulse oximeter and the capnography show they're hypocapnic and hypoxic, they're probably having a PE. You probably have a pretty significant ventilation perfusion mismatch on the perfusion side.
what will that
And I
waveform?
didn't
What will that waveform look like?
normally the waveform would be okay, because the waveform really indicates broncho more. I mean, that's what we normally would use. And now, when I got to the doctor's office and gave him my HPI, he said, "Okay, yeah, it could be this, it could be that. Yeah, it could have been a pulmonary embolus. It could have been an arrhythmia, like you initially thought. But I'm going to order some tests." And so he orders a battery of tests, and I was going to take them across the street to the hospital to have the labs drawn. And as I was ready to walk out of the exam room, I said, "Hey, wait a minute, I got something else I want to ask you about." Unrelated note. I think I strained a calf muscle a year ago, and it has been nagging me ever since. And he said, "Okay." And I said, "Yeah, it was at a literary con in Tulsa, literally a year ago, and I've limped around with my left calf hurting bad the entire conference, and it waxes and wanes. It's a nagging injury, and maybe I need an MRI and see if I tore something." And he wheeled his stool over there and examined my lower legs for about 30 seconds and looked up at me and said, "Do you realize how much larger your left calf is than your right?" And I looked down and went, "Well, I'll be damned." And he just rolled his eyes and said, "I'm adding a D dimer, a venous Doppler study of your left leg, and an echocardiogram CT angiogram to your left unspoken were the words, 'You idiot.'" And that's what it was. The D dimer was extremely elevated. And the venous ultrasound tech said, "Nah, you didn't have you didn't have a DVT. DVTs hurt too bad. You wouldn't have been able to stand the pain." I was like, "You don't know paramedics very well, do you, sister?" I said, "I think I've been dealing with this for a year and ignoring it." And she said, "Yeah, whatever." And 5 minutes later, she said, "Well, you made an effing liar out of me. I've got a clot in my posterior tibial vein, popliteal vein, and distal femoral vein, or one big clot that extends that far." They were never quite clear on that. And the CT angiogram showed bilateral large pulmonary emboli in the left distal main pulmonary artery and both segmental branches, and in the right pulmonary artery, all three segmental branches. Basically, I had severely compromised blood flow to 100% of my lungs. And I suppose it could have been worse. It could have been a saddle embolus that killed me dead right then. But it's only marginally better. It's pretty bad pulmonary embolus. And
Yeah, I mean, that's crazy, man.
The echo,
It could have
yeah.
been worse. I could be doing the show with Ruben Farnsworth now. So that's really how.
The echo was good, and the CT angiogram of my coronary vessels was good. Echo was fine. There was no hypotonic wall movement. Valves were all patent. Blood's flowing well. Didn't damage my heart. My BNP was elevated. It was about 1200. The best they can figure is that was due to right ventricular strain during
Yeah,
the
of
acute
course it
event,
is.
and that should normalize as time goes on. And I just have to break up the clot now. Take my
Yeah.
anticoagulants and wait.
Yeah, it's a good excuse to get in shape, man, isn't it? I mean, the alarm went off. Either you hit snooze or you get the heck up and you do what you got to do, right? So, I mean, I was joking, right? I said, it could be worse. I could be
Yeah.
doing the show with, Ruben, and I just picked Ruben's name out of the air. Ruben, how you doing? But you're lucky to be alive, is the point I'm trying to make here. That's how it could have been worse. Is you were very close to. I
Yeah.
mean, when we think about this, Kelly, this could have been hours, right? Hours or days that
Yeah.
it would have been the last time that we talked. But I mean, let's talk a little bit about the treatment, though. I mean, when you talk about something that's so prolific, I mean, something that's throughout your body, thrombolytics, embolectomy. I mean, considerations.
Apparently, yeah, those are definitely considerations. It seems now that the approach to PE and DVT is they tend to only go the surgical route if it's non-responsive to thrombolytics,
Interesting.
or non-responsive to anticoagulants. So I I probably would have the ER during the acute event, and it was going on. But by the time I added that, the clots wound up where they're going to wind up, and that's it didn't kill me, and we'll move forward from that premise. And they thought that a conservative approach with anticoagulants was the way to go. My coag panels are fine. I don't have any problems or any inappropriate clotting time or anything like that. One doctor, one associate of my primary care physician called, gave me my CT angiogram results and scared the living daylights out of me, because he ordered like a double dose of Eliquis and said, you're going to be on it for the rest of your life. And yes, you had a massive pulmonary embolus and you're lucky to be alive. Okay, talk to you later. Click. That was all I got.
Healthcare at its finest.
Yeah. F on bedside manner.
And
And
the
my
F doesn't stand for
physician,
failure.
no, it does not. I said some of those F bombs afterwards. I immediately called my doctor, and he talked me. He said I wouldn't put anyone on Eliquis for the rest of their lives,
Right.
unless they had a clot of unexplained origin, or their coag panels were off, and they were inappropriately clotting. So your coag panels are fine, your labs are fine, your lipid panel is far better than it has any right to be. You almost died, but truly, you're lucky to have as few medical problems as you do with your lifestyle and your weight.
Yeah.
So,
So I mean, but
knock wood.
how are you now? I mean, so we think about it. Your prognosis. I know you're back to work now. You talked about.
Yeah.
We talked just before we started recording that you ran your first code back yesterday. So I mean,
Ironically,
what are they saying?
probably a massive pulmonary embolus that it killed the patient.
I don't know that that's ironic, man, but
Yeah. I definitely felt, the cold hands of the Reaper kind of brushing my neck, going, "Hey, this could be you."
that's right.
I'm okay. By the third or fourth day after this, the exertional dyspnea was pretty much gone. What has really been the challenge is the psychological. I have depression, and now I've got another voice of doubt whispering in my ear going, you really don't need to get up and do this. You need your rest, and
Right.
and listening to that stupid little voice in my head that tells me to do all the things that are not good for my depression, or tells me not to do the things that will help me out of my depression. Telling that voice to shut up. You can't get in shape. You got to recover first, and that's what I walked out of the doctor's office with is you can't let your depression tell you tomorrow's a good time to start. You got to start now.
Right. Right.
And so
How's that been going for you?
I'm down about 20.2 pounds. I haven't weighed again. I'm about 20.2 pounds below my heaviest weight. I don't have any exertional dyspnea. I was significantly worried. I missed 2 paychecks, and paramedics missing $4,000 or $5,000 worth of paychecks unexpectedly sucks. But he said, you're not risking anything medically. You are limited only by, the Eliquis is the standard therapy for this, and it will help prevent further propagation of any emboli and start dissolving the clots that are there. He said, you are limited only by your pain threshold and how much exertional dyspnea you're willing to tolerate. And I was like, well, hey, I got both those off the charts. I can tolerate a lot of crap, as we well know. So I was worried about having to work my first code or go to one of the casinos, and your patient is over in Annex B of BFE, and you have to push your stretcher through a half a mile of plush carpeting laden to get the guy who has a hangnail that he wants to refuse care for. I was worried about that because that's a chore even when you're not feeling sick. But thus far, no problems.
Good.
No exertional dyspnea. Running a code in my position is it's only physically taxing if I'm there doing CPR, and I'm lucky enough that I rarely have to be the one doing compressions. And my knees and my lungs thank me for that. So I, got the patient's airway and got the vascular access, pushed the drugs, ran the code. But it was nothing really physically taxing, more mentally. Doing pretty good. I have to play the wait and see game, and I have to get my fat ASS into shape.
Hey,
Plain
Kelly,
and simple. There is no other way about it.
let me ask you a question. I mean, for someone, I
Yeah.
know that you've been, depression and so on. You've been very, very open with that, which I think is very admirable as well as a host of the podcast. Other people out there who have the same challenges, no, they're not alone, right? But when you think about
Yeah.
something like this, when do you flip the coin on things like weight loss surgery? And I mean, is that even consideration? I mean, should somebody who's having these events now start to think about some type of bypass, gastric bypass, or the Obera balloons that they put in the stomachs now, and those types of things? I mean,
Yeah.
so because a lot of people will get the weight loss surgery secondary to physical ailment, right? The challenges, diabetes, high blood
Yeah.
pressure, so on and so forth. I mean, when do you flip the
Yeah.
coin on something like that to say maybe I can't do it because of my metabolism, because of my genetics, and I may need to do a little bit something more drastic?
I think well, first of all, looking back on this episode, I have a very almost unlimited capacity for self-delusion. And prior to this, I'd always been resistant to the idea of bariatric surgery because I'm very stubborn. I tell myself that I can lose weight if I so choose, and it's just a matter of perseverance and willpower. But yeah, bariatric surgery is on the table now. I gotta admit that um, that might be an option. I don't think it should be for me, and I'm not going to go that route right now, simply because it's not like I don't lose weight when I try. When I try to shed the pounds, they come off quick. The problem is my mental state preventing me or making it more difficult to stay in that mindset and be diligent with my exercise and my food choices. It's always been simple for me. Expend more calories every day than you consume. So I set a calorie limit, and by setting that calorie limit, I eliminate calorie dense foods like heavy carbs and fats, and that works for me. And Chris, years ago when I was working at the hospital, we had a weight loss challenge at work, and I lost close to 90 pounds in 5 months, and did not feel bad. I felt great doing it. It's not like I was starving my body. And I can drop the weight big time. The question is putting in the thing. Limiting factor is being diligent and sticking with it.
Yeah, but when you're close to death, Kelly, where you've been, I mean,
Yes, I know. That's why bariatric surgery is on the table.
I mean, just craziness. But yeah, let me get to the last question. I want you to hit me with
one more thing on the bariatric surgery though. But it's one reason I've been resistant to it is because it is life-altering surgery. I mean, you can have the lap bands, the constricting bands and everything, and they can adjust those, and it's not that big a deal. But cutting out part of your stomach and stapling it, I've seen so many people have metabolic disorders and digestive disorders following that, and all sorts of problems maintaining adequate nutrition. Because you're eliminating part of your digestive system, and some people don't deal well with that. On the other hand, compared to the other health risks that obesity brings, it's a good choice in many cases, but I don't think it's appropriate for me yet.
All right. Well, good. So, well, give us a couple of the lessons learned, and then maybe just talk a little bit about if a paramedic comes across a patient that is experiencing what you did, give them a couple tips, and then close the show for us.
Yeah. Lesson number one to our fellow caregivers: be good patients and don't be stupid about your health. And we are the world's worst at taking care of ourselves. We will sit there and lecture patients about a healthy lifestyle while drinking these. Now, I will say that down to 1 or 2 a day, not a 6-pack or an 8-pack a day. We'll lecture patients about healthy lifestyles, and then after the call, go smoke a cigarette. And we cannot do that. It slapped me upside the face on April the 14th that it's time to actually start talking, walking the walk about your own health. So even if you have the capacity to rationalize and the capacity to be clinically analytic during your own medical emergency, ultimately all it's going to do is give you the peace of mind when you die that you knew what killed you. So don't be stupid and ask for help when it's needed. Treating the sort of thing you have with a massive PE, if it's a massive PE that includes major blood flow like a saddle embolus or a staghorn embolus, you're going to see hypotension, you're going to see hypoperfusion, massive circulatory collapse, and this is quite often the code of unexplained origin that we work with, or the one night where the patient had a major surgery literally the day before and collapsed this morning with no warning. But if you have a patient with respiratory distress of unexplained origin and they're ventilating appropriately, their lungs are clear, they're not bronchoconstricted, you might have a ventilation perfusion mismatch that you're having to deal with. And one of the things that the major clues is look at your pulse oximetry and your CO2. Someone who is having a pulmonary embolus will likely be hypoxic as well as hypocarbic because they're not exhaling CO2 for you to detect, as distinguished from simple case of hyperventilation syndrome where their CO2 is very low because they're hyperventilating, but they've got 100% oxygen saturation. So look at those things and look at risk factors. I ignored a major risk factor. I got my DVT after an 8-hour car drive. It's so classic, it's almost stereotypical. And I sat and ignored it for a year, and was so unconcerned with my own health that I didn't know my own leg was significantly swollen for a year. Don't be that guy. But when you have a patient with unexplained sudden onset of respiratory distress, but mechanically they're ventilating well, be really thinking about pulmonary embolus, and treat accordingly. Get them to the hospital, get them to a place that has cardiac cath lab capabilities and can do an embolectomy or administer thrombolytics. But hey, that's we told you what I thought, which I wasn't thinking. We'd like to hear what you think. How's your health? Are you taking care of yourself? Did me almost dying scare you into it? Let's hope so. But for myself and co-host Chris Cebollero, thanks for tuning in to Inside EMS. We're going to catch you guys next week.